right, so this is me. I really go by my middle name Zara, but it's Ellie Zara Lay. My pronouns are she, they. I'm a certified plastic surgeon, and my background is pretty diverse. And so when I was going through it, it seemed like I was doing like training after training after training, just to kind of be the best I could be in terms of plastic surgery. And so I racked up all these degrees. And many years later, I came into gender surgery and had the opportunity to train under one of the most experienced gender surgeons in the country and even in the world, certainly now because he's near retirement. So Dr. Meltzer trained me, took me under his wing, trained me in doing all aspects of gender surgery. And he learned this kind of the hard way back in his day when there were like maybe 4 surgeons in the whole country that were offering these things. And so he had to learn and develop a lot of techniques to where it has led to today's modern ways of doing gender surgery. So I was very fortunate to be taught by him, but also work alongside him and keep learning throughout the, I think, 7 years that I was there. And so I do offer comprehensive gender surgery. The only things I don't do are like voice surgery. I don't do the gynecological stuff like oophorectomies or hysterectomies, but I do perform my own vaginectomies for my patients, and I don't do hair transplantation. But aside from that, I basically do everything else. We do go by the most recent version of the standards of care as set forth by WPATH. But one thing I say in these talks is that insurances aren't quite caught up to the new standards of care. So the patients that are going through insurance for these procedures, they may have to come up with 2 letters or have to meet certain time requirements as if like how long you've been on hormones or seen a therapist, that sort of thing. And unfortunately, they're the ones covering the procedures. So you're, basically just go along with it and meet the requirements so that you can get your surgery and get it covered through insurance. Otherwise, especially masculine surgery, cash prices are can be incredibly high. And some of the procedures I do for bottom surgery, I don't even offer any sort of cash pricing for it. Unless you're like a billionaire or something like that, then maybe, but it's incredibly expensive to do some of these things without insurance. But these are some of the basic requirements. 1 letter, and again, the whole insurance thing. 18 years of age for bottom surgery. Hormone therapy for a year, although that's kind of flexible, again, going back to insurance. Now, being on cross-gender hormones such as testosterone can be helpful for certain of the procedures that I'll be talking about, because it does have the effect of enhancing the genitalia. And so it makes it easier to do some of the surgeries, but also to get more noticeable results being under testosterone. But saying that, everybody is different. People react differently to testosterone, meaning some people can have incredible growth and enhancement, and others, despite being on years of testosterone, their bodies just don't quite have the right receptors for it, or whatnot, and then the enhancement isn't as good as it's expected to be, even at the average level. So all of these things have to be taken into consideration when speaking about certain procedures. All right, so this is masculine bottom surgery. So let's talk about phalluses, starting with my dog. And so this is my dog, Edison. He started off very sweet, and then he turned into a total jerk. So he's always getting in trouble at daycare. And recently he's been put on solitary confinement. And now he's back in Gen Pop at the daycare. So he's allowed to go back. But he's always causing trouble. All right, so there are a lot of procedures under the transmasculine bottom surgery, I guess, menu of options. So it can go from relatively simple, none of this is actually simple per se, but relatively simple to very complex. And so this is a kind of a bit of a scale of going from simple to complex, simple being something like simple metoidoplasty, all the way to microsurgical phalloplasty, and then all the other surgeries associated with the phalloplasty. I'll be going over this. And so this is like one of the early versions of this masculine bottom procedure flow chart that I came up with. Actually, this last weekend, I worked on it some more. It's an ongoing process to come up with a very comprehensive one. And I'm working towards having a program or something like that where patients can come and use this tool and basically, run through the different options so that at the end, as they say, yes to this, no to that, yes to this other thing, that at the end of finding their path through the flow chart, it'll come up with a summary. And I think that would be very helpful, not just for patients to figure out what they want, and also be presented with all the different options that can be done. And, maybe even taking that to the gender surgery center that they're going and be like, this is what I would like, and have that discussion with the surgeon, whoever that may be. So I am working on this. Like I said, I did that some last weekend. I'm hoping to do more this coming weekend. All right, so let's start with, again, the simple, right? Most sort of basic type of bottom surgery. And of course, everybody has an idea of what they want. And so simple metoidoplasty is a relatively safe, low complication rate procedure with the goal of basically tubularizing and enhancing the phallus that has hopefully been enhanced and has grown because of being on testosterone. And so I have to release tethering structures that keep it in the down position, from at the beginning, and that's how it develops. And so I have to release a ventral chordae, which is on the underside of the shaft of the phallus, in order to get it to sort of pull up and out. And then I wrap the skin around it to make the shaft and make it into a more tubular structure. Now, the suspensory ligament I listed on here, and as of, I guess, the last couple of years, I am more selective about who I do the suspensory ligament on, and I only do it now if I think that as I'm doing the surgery that there can be some gain in the release and the length of the shaft. Then I do it, but it's not routine anymore just to do it for the sake of doing it. And I have had patients tell me specifically that they don't want their suspensory ligament divided because their erection, maybe a little bit more wobbly because it's not so sort of grounded or attached to the pubic bone. So again, one of those things that I do weigh when I'm doing the surgery as to whether it's beneficial to that particular patient. This is an example. I mean, this is right after surgery. And so many patients wonder, what kind of penis do I get? Do I end up with a circumcised look or an uncircumcised look? And so technically, the way it's done, it comes out as a circumcised look, but sometimes, and I may have a picture of this, sometimes depending on the person, when it's not erect, the skin kind of rolls over the glands, and it then has kind of a uncircumcised look until it gets erect and the skin kind of pulls back as the shaft gets hard. And so in this particular patient, I did do a suspensory ligament release. You can see there's a dimple at the base of the penis. And that's partially because I tacked the skin down to the top of the shaft and the pubic bone so that skin doesn't tent, and it helps to keep the phallus more phallus or tubular-like by doing that. Otherwise, basically like the hood, what used to be the hood tends to kind of be like too much extra skin. So that's something that I can do. As part of the simple metoidoplasty, this is, again, some of these options along the flow chart where I do ask the patients at every consultation for simple metoidoplasty what they want to do with the labia minora. And it's mixed and very individual. Some folks don't want it because it's too much of what they started with, and they're not comfortable with that. But others have no issues with it and they want it preserved. And so that's, a question I ask my patients. I do have to cut it because it's attached to the glands and the hood. But I then sort of clean it up, repair it, and then put it under so that it looks as natural as possible. So this is just one of those examples. The incisions along the sides, as you can see, there's like skin glue over it. It's just a line underneath, but sometimes the blood and the glue mixes, so it looks like, it looks bad, but it's just a line underneath. And this is done, these two lines that you see, this is to reduce the fullness adjacent to the phallus so that it doesn't cover it up. It's like the top of the labia majora, and so by flattening it out, there's more genital show, if that makes sense. But this is an option, and I ask everybody about this. Now, of course, you can also combine this with scrotoplasty, and then move on to the options of either testicular or scrotal expansion and testicular implants, or go scrotoplasty and then direct to implant. It really just depends on what the patient's goals are and what their anatomy is, how that plays out. Here's another labia minora preserving one. You can see the penis is very, shaft-like, tubularized. This patient had quite a bit of enhancement. The labia minora were a bit on the big side, and And so I just put it under, and that's what these are. You can see the little stitches of where I repaired it from where I had to separate it to do the metoidoplasty. So again, keep that in mind as an option. In the past, when I first learned it, I didn't know that that could be an option. And so I automatically just cut them off on everybody, not thinking or knowing that some patients may want to preserve them, but they didn't know that they had that option. So I have the previous picture, that person to thank, to sort of make me more aware of offering more options and involving the patients in this type of decision making about the different parts of their anatomy. Just another view of this. All right, so moving forward, one step up from the spectrum of simple to super complex reconstruction is the metoidoplasty with primary urethral lengthening. That's where I reconstruct a urethra so that patients have a chance of perhaps standing to pee. It's not everybody's goal to stand and pee, but it's a common reason why patients choose this option. It is higher in complexity. There is higher risk and complications and more involved recovery. Going back to the simple metoidoplasty, it's an outpatient procedure. All the sutures are absorbable, and patients don't have to be in the Bay Area for that long. They can go home and recover there and not worry about having to go to a local clinic or a doctor's office to get stitches taken out. This is a little more complicated. You're committed to being here for at least 2 weeks to get through this process. And so I use labia minora tissue to create the urethral reconstruction. A lot of folks ask me, well, how do you do it? Or where does this tissue come from in lengthening the urethra? The other thing that's commonly asked is whether I preserve the periurethral glands. And the answer is yes, I do preserve them. So that, if someone has very active periurethral glands, they can have secretions or even be able to, I guess, squirt. So I do preserve those. Now, the way I approach metoidoplasty with urethral lengthening is that I absolutely require a hysterectomy and a vaginectomy to be done, preferably the hysterectomy done ahead of time, because I can't do a vaginectomy without someone having the hysterectomy, right? There needs to be outflow for the uterus. So yeah. Vaginectomy. And the reason why I require that is because it lowers the rate of complications. And this has been, proven with, surgical studies comparing metoidoplasty, urethral lengthening with or without vaginectomy. It's much, much higher rate of complications without the vaginectomy. And one of the theories of why doing the vaginectomy helps is because you close that space that's underneath, right? Urethras, right below the urethra is the vaginal canal in the original anatomy. So by taking that canal and space down below and collapsing it and having it scar down sort of forms a buttress or a foundation for the rest of the anatomy. And so it's like a foundation to like a house or a building. So that's one of the theories, that it's more stabilizing, so there's less risk of complications. Here's just an anatomical depiction of what urethras are like. There's different layers. It is spongy, but it is smaller. It is smaller in our transmasculine and masculine non-binary patients, but they still have all the same structures. Now, the extension of the urethra in the urethral lengthening is simply a skin tube. We have not yet found the way to create these complex layers to build our urethras for the masculine patients, but maybe someday that will change. These are those periurethral glands. And so you can see there's all these little dots here. And so here's an actual picture and an anatomical picture. And you can see that there's little kind of like pinholes surrounding the urethra. And they're not difficult to see. And so when I make the incision to cut around the urethra to become the cuff of the extension, I include the ducts in that construct instead of cutting through them or cutting them out. And that's how I preserve it. Sorry, this is graphic. I should have warned you. It is a surgical talk, but these are actual pictures, and it's sort of hard to follow because you're like, oh my gosh, it just looks like, a bunch of open tissue. But this is kind of the way it's done. It's tacked this way because I pull things apart so that I'm able to visualize and make the urethra. Obviously, it's not permanent. It's just for exposure. And so these are the flaps where I create the urethra. There's certain measurements that I have to follow, and that's the labia minora. So on picture A, the labia minora has been splayed open, and you can see bits of the labia majora underneath it. So these flaps get elevated, and then they get sutured. Of course, the ventral cord gets released underneath it, and then it starts getting tubularized to become the conduit. And of course, it gets sutured around that cuff of the original natal urethra with the ducts intact. And then the skin is sewn over it. And that's basically how it's created. Of course, the vaginectomy has been performed. I don't show it here. And that's how it's done. It's hard to sort of follow the sequence of, I guess, the surgical steps, unless you're there. And anyway, but that's how it's done. Okay, I explained why we do the vaginectomy, but the question is, how is it done? I had this conversation this morning with a patient who is going to have this surgery, is why I do the vaginectomy, but also how I do the vaginectomy. There's different ways of doing it. I do it by excision of the vaginal lining, all the way from the entrance all the way to the apex, where the scar of the hysterectomy is. Of course, the cervix is gone because that goes with the hysterectomy. So all the way up to that apex, I excise it. It's a bit tedious to do it this way. The other alternative of doing it is fulguration, which basically means burning the lining of the vagina. And some people do a combination where they excise or cut out the lining, like let's say the first third or first half of the vaginal canal, because it's easier to do. But then the deep end of it is harder to do. And so they burn that part. So it can be a combination. I do full excision. Some of the potential risks of doing vaginectomies is going too deep and then injuring adjacent structures, which luckily, knock on wood, that hasn't happened. But have I seen it happen? Yeah, I have seen it happen. I wasn't in the surgery, I was watching it. And the person, not Dr. Meltzer, the person basically punctured the bladder through the vagina. So that was a bit of a mess. So you have to be careful, and obviously you have to know what you're doing to do this. Colpoclysis is simply basically closing the residual space after a vaginectomy, collapsing it. So again, I also do that. Can you get in trouble doing even just the closure of it? Yes, of course. If you take too big of a bite, you can actually, especially in the very, very back, you can actually catch a ureter, which is where your kidneys drain into the bladder. So that's also not good. So again, luckily, that's not something that has happened for me anyway. And I'm very conscious about that. Because after seeing some of these things happen, I don't want to do that. So, all right. So, I talked about the risks. All right. So what are the complications of metorrhaplasty urethral lengthening? I would say the most common one is a urethral fistula. Now that can be pretty small or much larger. And so there's a way to fix it, but it usually can't be fixed right away. It's not something you run back to surgery, 2 weeks later, 10 days later, and be like, oh, let's just close it again, because it doesn't work. There's too much inflammation. The tissue has been, surgically traumatized in just doing the surgery, and it tends not to work that way. So what does this mean? It means that the suprapubic tube that I put in for this procedure, which is required for this procedure, has to stay in longer in order to divert the urine going through the newly constructed urethra to give it a better chance of closing. But it can also mean multiple surgeries, having to come back, especially if you're from out of the Bay Area, or all the way in the East Coast kind of thing. And it just takes longer to basically get you there and fix these things. Now, it doesn't happen to everybody, but these are the potential complications. If it's paired with scrotoplasty, the scrotoplasty itself can dehisce or come apart, especially at where the flaps kind of come together in the middle. And that usually takes time. And again, it doesn't require additional stitching or anything like that in that immediate acute, like postoperative period. Sorry, I've been talking all day. I've had clinic all day long. Okay, so so after these procedures, whether it's a simple metorrhaplasty or a metorrhaplasty with urethral lengthening, there are ways of actually continuing to try to enhance the phallus. And these are just some known ways of doing it. This is like a Chinese finger trap type of thing over the penis using fishing weights to sort of keep it stretched. You have to be careful with some of these stretching techniques because you can't just put it on in the morning and walk around all day long like this because it's too much tension, and you could actually be hurting your phallus or hurting your urethra. But it can work when used appropriately. Manual stretching is probably the safest, but it requires like obviously actively like pulling on it and holding it for quite a bit of time. This is another way where folks take a rope and they basically sort of wrap it around to get it to like push out more. And the rope kind of keeps it in that stretched position. And you can imagine that this is definitely not something you put on before you go to bed and then you sleep through the night with this because you could really hurt yourself by cutting off blood supply. Again, used correctly, it can help you. There's my dog again, drooling because I'm feeding him snacks. All right, so that's the sort of more simple metodioplasty type of reconstruction options. And now we're going to the phalloplasty options, with phalloplasty being defined as constructing a penis of a quote unquote proportional size. So these are, again, like I'm saying, we're going down the spectrum. So it's higher complexity, higher risk, and it's much, much more involved. It requires more recovery time, multiple surgeries, and quite a bit of time to go from the beginning to the very end. Again, depending on the patient's wishes and how many options they want to add to the phalloplasty. But this allows patients to have penises that are, I mean, my goal is sort of 5.5 inches. Sometimes with growing flaps, depending on the size of the patient, they can get pretty long. I've also seen ALT flaps that are pretty long. But of course, it depends on the patient and how much tissue they have, what the proportions of their limbs are, as in radial forearm type of phalloplasties. Then one thing to know about phalloplasties is that once it is made, it's basically a static length. And what I mean by that is that whether it's flaccid or it's erect, it's the same size. It's not like the natural thing where it's, sort of flaccid and smaller, but then with the erection, it gets, thicker and bigger. It's not like that. It's always basically the same length. Now, erogenous sensation can be an option on some of these, but only on certain types of phallus reconstruction. I do go over these. Urethral reconstruction is optional. I do have patients that have requested having a phallus, but they don't intend on putting a urethra through that phallus. And down below, they may not have anything done, or they have a metoidoplasty, urethral lengthening underneath. And so again, those are potential options to just have a phallus and nothing else. Erectile devices can be placed and they are optional. And I also go over that. But it takes years to complete this process if you want to go, I guess, the full package all the way. Going back to the flow chart. You can see just from presenting the metoidoplasty side of things, there's a lot of options and a lot of different ways someone can pick and choose how to get there. All right. When we talk about phalloplasty reconstruction, you might hear things like pedicle flap or microsurgical flap. And what does that really mean? A pedicle flap basically means that you take tissue from one part of the body, but you don't disconnect it. You keep it connected, usually through the blood supply of that flap, and then you either put it somewhere else and flap it down, or in our case, we turn it into a penis, right? We roll it, make a tube out of it, and then place it elsewhere to create the penis, but it is still connected to its original blood supply. That's a pedicle flap. It's tethered by that tissue. A microsurgical flap is tissue that is completely divided and taken off the body and then transferred to a different site. As long as that flap has defined vascularity, and then wherever you're going to put it has adequate recipient blood vessels to connect that to. And nerves can be taken with these flaps, again, depending on which flap it is, and connected in order to have sensation grow into the phallus. This is one of the options. I don't do this one, a partial latissimus dorsipedicle flap, or even a microsurgical flap. These tend to be very bulky, very big. I've certainly done my share of these for limb salvage and breast reconstruction, but I haven't done it for gender surgery as a phallus option. I think they come out too thick, even though they have a very well-defined and strong blood supply. That's not too hard to sew because the vessels are larger. But that's an option. There are places that do offer this. I have to credit the website microsurgeon.org. It's out of the Bunkie Clinic. And they have all kinds of flaps and drawings, and it's pretty useful. Even as a surgeon to go back and look at these things. This is a microsurgical flap. This one happens to be a radial artery. I don't know what they're constructing with this one. This is just a picture that was on the website. But we take a much larger patch of tissue from the forearm for the purposes of making a phalloplasty. But again, you can see that that tissue is completely taken off. And that's what microsurgery is. Okay, so what are the options with these flaps now that you know what pedicle flaps are and what microsurgical flaps are? Under the pedicle flaps, the most common one, or actually, the most common one I do is a groin flap. There's another practice here in the Bay Area where they prefer abdominal flaps, kind of the same concept, just coming from different areas. And then the ALT flap, which is a lateral thigh flap, is a pedicle flap. But sometimes the vascular leash is too short and it's hard to make it reach the center of the pubic region, right? Because you don't want a penis that's off to one side. And so in those cases, if I find that the blood supply or the leash of the ALT flap is too short, I don't hesitate to completely cut it off and then turn it into a microsurgical procedure. But I don't do very many ALT flaps. I'm very selective on who has that. I'll go over it in this section. Microsurgical flaps, the most sort of popular version of the microsurgical flaps is a radial artery forearm flap for reconstruction of the phallus itself, just by itself, and the phallus with the urethra inside of it, what I call the tube within a tube design, right? The inner tube is the urethra portion, and then the outer tube is what wraps around it to create the outside of the penis, so tube within a tube. ALT flaps, like I said, can be microsurgical flaps. A skip flap comes from the groin, and it's taken off. It's almost like a groin flap, except that it's completely taken off instead of having its attachment. And I brought up the latissimus dorsiflap, which in the case of phalloplasty would have to be a microsurgical flap because you have to remove it. It's up here. This is the latissimus back here. And so obviously you can't make that reach down to the pubic region. So it has to be divided. All right, groin flap phalloplasty is a stage procedure. There's one major procedure where I make the phallus, but then it's connected. Sometimes it's referred as the bucket handle phalloplasty because it looks like the handle of a bucket. I have a picture of what that is. And then there's three minor divisions. So the divisions or the delay of flaps means that I have to slowly cut away where the original blood supply and pedicle is as the pubic end of the flap starts building blood supply from the pubic region. And so it has to be, you can't rush it. You have to let the body like grow and get strong blood supply before you can fully divide the pedicle, which is on this side of the groin. The whole process takes about 3 to 4 months with the delays and everything. And of course, if anybody has any sort of wound healing issue or wound compromise or tissue compromise, it just pushes everything back because you have to fix that or let that heal before you move on to the next stage. This flap doesn't have a defined sensation, so it's non-erogenous. You will get sensation eventually, but it's basically kind of dullish skin sensation rather than erogenous sensation. I don't make groin flaps with a urethra in it, so I make them as phallus only. And then I offer patients a different flap to create a urethra to go inside this groin flap, typically a radial form. But that flap is much smaller, so patients are more accepting of having a small scar in the forearm rather than a big patch of forearm taken off to create the tube within the tube radial form phalloplasty with urethra inside of it. This is sort of a depiction of how the groin flap is done. That's the blood supply that's original. You can see that it's off to the side. This one's an ellipse because it's just from the website, but I cut out a rectangle and then I roll it. You're in the hospital for 1 to 2 days, general anesthesia. It takes probably 3 hours to do it, to do this. And then where that tissue comes from, I close it primarily, so it's one long line. It's not uncommon to have a dog ear at the very far end of the hip, which is not an issue because at the time of a glanceplasty, I take that tissue, get rid of the dog ear, but that tissue that would normally be thrown away in a dog ear revision, I use that tissue to for dermal grafts to make the head. That's what I mean, the bucket handle. You can see that it's connected. From the right groin, you can see the kind of the design of the flap, and then the wound where it's closed, you can see that long line along the groin, even though there was a big patch that was taken out, and the penis was flipped on its side and sutured onto the pubic region. And slowly it gets cut to the point where it gets released. This is one of them, and I can't remember if it was right before the last release or not. But once I release, I do the third division, it becomes a full penis and it hangs down. This one came out pretty long. I do use intraoperative angiography as a tool in doing phalloplasties. I use it in all cases to make sure that the tissue that I've transferred is surviving. So this is a picture of the groin flap phalloplasty with full perfusion throughout the entire thing after I made it and then flipped it over onto the groin. I know it's hard to sort of interpret some of these things, but that's what it is. This is just an example of kind of a finished product. And so you can see that this patient has a scrotoplasty, a glanceplasty, and testicular implants. So pretty good. ALT flaps, it's also a staged procedure. It comes from the thigh. It tends to have a good length as well as a good girth. But one of the criticisms of this flap, if you don't choose the patients carefully, is that they can come out very, very large and very, very thick. I've seen these. The ones I've made have been smaller and not so girthy, but I've seen them where they are maybe not quite the size of a standard muff, but pretty close to it, but like thick, big like this. And so, the patients have actually come in to see me about making it smaller because it's too big and it's kind of unusable. So anyway, I tend to be very picky on who I do ALT flaps on. This one does have sensation and vascularity. You can put a urethra in it, but I do it as a second stage using a different flap. Other places will do the tube within a tube design, but I think that's how you end up with a very, very large penis and urethra. Again, from the microsurgeon website, these are the blood supply. This is the blood supply. Those are the perforators that feed into that flap of skin. And so I have to find them with a Doppler, sort of an ultrasound thing, and then follow it down to its main branch, and then follow that to its main branch in order to release it or transfer it. It has potential nerves where I can connect to. And these are some of those sort of genital area nerves that can be found and identified and connected to the nerve of the phallus. These are just different versions of these nerves and sort of what areas they provide sensation for. This is after surgery. This is the first one I ever did. This was in Arizona. It took a pretty good beating. And I was, you can see that it's kind of discolored, quite bruised, but it recovered and did fine. You can see the wound vac dressing on where the flap came from on the right thigh there. And that was eventually grafted. But the patients that I pick for this have to be very, very thin. There's something called the pinch test. It's kind of a generic sort of quick sort of test about who is a ideal candidate for this. And it basically means that you pinch the skin in that area of the thigh. And if it's about a half inch or less, then you're considered a candidate. But if it's an inch thick, when you pinch and pull that tissue off of your thigh muscle and it's bigger than that, then for me anyway, that's not a candidate for an ALT flap. Some people choose this because the donor side, where the flap comes from, is more easily concealed as long as you wear longer shorts. And of course, if you're in pants, then, it's also more easily concealable. You're in the hospital for 6 days. You're expected to commit to staying in the Bay Area for about 4 weeks. Different places have different requirements. I've heard 6 weeks commitment to stay in the area after these types of surgeries. These are very, very long surgeries. And then I have to also address the donor side, which I usually use a collagen sheet to help build up that wound. And then come back and do a split thickness skin graft to cover it. There are other ways of dealing with that scar, like tissue expansion. I think one of the practices here does that. And they even do sort of prefabricated or pre-lined ALT flaps. But I don't do it that way. But that is a possibility. All right, the last one, radioform. So the radioform tissue is a very, very good flap for all kinds of reconstruction. It is used a lot for head and neck reconstruction, and basically anywhere, because it's usually very reliable, good vessels, good size vessels, and it's thin, so you can shape it to fit many, many things. And so this one has a sensory nerve that's a pretty good size. People think, oh, like, how do you see the nerves? They're actually the bigger nerves. You can actually see, I don't have anything here to show you kind of what size they are, but they're certainly not hard to miss when you're obviously trained and you know what you're doing. So I preserve these, and when I transfer it, in order to get erogenous sensation, I connect it to one clitoral dorsal nerve. And after about a year, you have a chance of having erogenous sensation through that penis. Again, it can be done with a urethra and without. This is an example, again, just from the website. This might be something similar to a radioform urethra. This is pretty close to it, although I don't know that that's what they're doing in this drawing or diagram, but it's pretty close. And with the radioform, the area is much, much bigger, as you can imagine. Same thing, it's a stage procedure. So this is the radioform urethroplasty. You saw the picture here. So if someone comes in with an ALT phallus, whether I did it or someone else did it, or they have a radioform only, or they have a groin flap, abdominal flap, any kind of phalloplasty, but they don't have a urethra, or the urethra failed in the past, then I do a radioform urethra, where I take the smaller area, I roll it into a tube, right, as a urethra, and then I place it inside of the existing phallus, and that's how I create it. And of course, then you connect it to the metoidoplasty urethral lengthening that has already been done below. Same thing as the ALT, very complex. So 6 days in the hospital, you commit also to being in the Bay Area for at least 4 weeks. These are also very long surgeries because the tissue comes off of the arm. I do consult hand therapy, and they start that while you're in the hospital. and then you continue it as an outpatient so that the scar that develops over your forearm doesn't like restrict or adhere to your tendon and tendon sheaths too much to the point where it may hinder your movement. Same thing as the ALT flap wound. I put a collagen sheet in it, a wound vac, which is one of those vacuum sponge machines, and then I put a split thickness skin graft or a full thickness skin graft to do it. Another way to make the urethra is a skip flap, which is kind of like the groin flap, but it's a microsurgical flap. And that one, again, is also very easily concealed. It can be closed primarily. You don't even need a skin graft for that one, for this one, but it's not commonly used. I've only done one of these. And it was successful. It was fine. It worked. But it's a little trickier to find these vessels, and they are on the smaller side. So I don't prefer it. But if I really have to in the right patient, I would do it. These are the skin markings for the urethral flap design. This one has an extension that you can see at the bottom here to help increase girth of the penis. And you can see where the extension goes, and it helps to kind of open it up. And once it heals, it looks pretty good. All right, so there's things that can happen with phalloplasty. So if patients have, I do require electrolysis. So if patients have hair in it, things can get caught in it. You know, people have a history of like bladder stones, they can form, but because it has to go through the new urethra, sometimes it gets caught in some of the little like pockets from the created urethra and cause problems. And that's me fishing some of these things out of the bladder. This is a urethra. This is not one of my patients, but maybe one of Dr. Meltzer's. He took this picture. And that's the urethra. So imagine you're literally peeing through like a sponge or sieve, you know, and because urine has chemicals, eventually it forms calcifications like hard water on like bathroom faucets or something. This is actually one of my patients, and that a clump of hair inside their urethra restricting flow. So I went in through the cystoscope and fished it out with one of these little wire trap things. And there it is, pretty big. You can see that's my hand there on that side. And then this is just me making a urethra. This is what phalloplasty, the little stitches on the dorsum help the nurses and my PAs and myself find the blood supply, because we check it a lot during the hospital stay to make sure everything is okay. This is a phalloplasty that has undergone, a radioform that has undergone glanceplasty. And I think at this stage, I can't remember what I was doing. Maybe I was connecting it to the urethral lengthening at the bottom. But complications can happen. This is one of my patients. So this patient, actually, no, this one's not my patient, but it could have been. And I do get fistulas just like this on my patients. This patient came from somewhere else, and they had a suprapubic tube for a whole year and had these fistulas. And I don't know what happened, but they basically left it in, and the patient moved and ended up in my office. And so I went in and fixed the fistulas. You can see there's 3 there. And I didn't know that there was another one at the tip. After I fixed this and I tested it, water started squirting out of this one. And so I found it, and closed it, got the suprapubic tube, and the patient's doing well. This is a metoidoplasty that had a fistula, and this is one of the ways I fix fistulas is putting flaps over it to basically seal the hole. Strictures are fixed with buccal mucosa in order to expand the inside of the urethra. Glansplasty means shaping of the tip. As you can see, this is that other one that I showed, but healed. Scrotoplasty is also an option. I use labia majora tissue to create this. And then, of course, you can expand it if you need to, or go direct to implants, depending on the size of the implant and how much scrotum was created and how stretchy it is. But this is an example of a metoidoplasty, urethral lengthening, and scrotoplasty. More examples. These are the tissue expanders for the scrotum. They have external ports, so it's easy to fill. And of course, last thing is the erectile device. This is a device that I use, and I modify it. I don't put two chambers in. Some people do, but I've also seen patients that had two placed, and it was too much pressure, too tight, and they had partial necrosis of the phalloplasty. So after seeing that, I'm like, nope, I'm not putting two in there. So I only put one. But complications with the erectile devices is usually infection, or over time, even after years, they can extrude. And once it's exposed, it's game over. You have to take it out, let it heal, and then come back in 6 to 9 months to put another one in. This is an example of a erectile device. It's just it's another type of erectile device. A patient came into the ER, basically with a pussed out erectile device. It was done in another state, like a few years ago, and it just kind of worked its way out. You can see that there's a hole there, and the patient was also draining from the base of the penis. The infection went all the way to the pubic bone region. Yeah. And that's it. And that's there's my dog and my family. So yeah, this is the talk. Sorry, it's a lot of material, a lot of sort of challenging concepts on how to do this. So you can imagine that in trying to create this flow chart that I'm doing, that it's not that easy. Not that easy, because even as I was doing it this past weekend, I'm drawing it out, all the different pathways, all the other options. I would do it and then go back to it, and I'm like, oh man, like I forgot about this other option and this other pathway. And so I'm trying to work on this so that hopefully, maybe not this year, but maybe next year it'll come out. And I think for our community, not just like GCC patients, but like open to the community to, play with this tool to figure out what they want. And again, you go through all the options, and of course you can like go through it over and over again, take different pathways. And then at the end, it'll have a summary of what procedures you would get. And so, of course, that can be expanded to have more explanations and even a timeline tied with it. But that's like, ooh, I'm getting way ahead. First of all, I have to create this flow chart that encompasses all the different options and all the different pathways that are available to our patients. So I'm going segment by segment by segment to create all these pathways. But it's pretty tedious. Anyway, so thank you. Thank you for listening to me. I know I went over. But any questions, Rai can moderate and ask me.
Yeah. Thank you so much, Dr. Lay. Just, yeah, so thorough. And
losing my voice.
You're
I'm
good.
planning today. I've been talking since this morning.
Yeah, you're good. Take your time. Yeah, just thank you again for all of this information. It's so complex, but you just went through it so thoroughly. And yeah, so many thank yous are coming into the chat. Thank you so much, everybody, for being here. We have a couple of questions in the Q&A, so we can tackle some of them. How are you feeling right now?
I'm good.
Cool.
I hope that audience is good too. I
Cool.
can't see the comments.
Yes. Let's see. First one is how common is fallow with keeping the vaginal opening?
Um, it's actually not that common. It's actually not that common, but it is possible. It's also possible with metoidioplasty and scrotoplasty to keep the vagina and obviously the original urethra.
Cool. Can Mons reduction be done at the same time as simple meta?
I don't, and the reason why that's a good question. I don't because the monsplasty creates so much swelling, and gravity wins. All that swelling runs right down into the genital region, and I did that once, and the metoidioplasty stitches popped open because of the massive swelling. And after that, I was like, never again,
Oh
never again.
no.
And so it healed, it was fine, but um, yeah, that was not good. This was many years ago, so I don't do it that way now.
For sure. For folks on HRT, is there a length of time that's optimal for shaft length? Is there a time when the clit will no longer grow?
Um, I think I think it's variable for everyone. I would say just like it is for the other side, trans feminine patients with like say breast growth or something. I think that after about 2 years, you've probably seen, the most you can see in terms of growth without enhancing it through like pumping or stretching. Although I do encourage that because it does work, but you have to be very disciplined and consistent with the stretching techniques. But I'd say 2 years on testosterone. Um, you're probably at your max. Of course, you can find examples. Like I said earlier, there's some people that are on testosterone for 5 years and there's barely any response to it. And people who are have incredible growth. As you can tell from some of the metoidioplasties I've done, that it's I would consider those very good growth for metoidioplasty.
Mhm. Cool. Are there any limitations on the length? And what limitations are there for functionality after full phalloplasty?
Yes, there is a limitation on length, but I think that depends on what type of flap is used. Um, and so my goal for phalloplasty is usually 5 to 6 inches, depending on the person. It can get to 6 inches, and I've done that. But the longer you make it, you worry about distal tip necrosis because the blood supply doesn't quite make it all the way to the tip because it's too long. Um, and so I don't want to see that, to see the tip um, not not make it. Plus, if it's a radial form, patients have to have long enough arms to take the flap from for that particular length.
For sure. What if a vaginectomy has been done by a different surgeon prior to a urethral lengthening surgery?
Great. Saves me a step.
For sure. Cool.
Yeah, no, I have seen that. But it's pretty rare for people to have had a vaginectomy.
Mhm.
Um, but yeah, I mean, great.
Cool. Um, This person says, what would the potential impact of course of intersex surgery at birth uh, on bottom surgery outcomes?
That one's a bit hard because intersex is it's rare for one. Um, true intersex, I've seen maybe a handful. Uh, but in the folks that I have seen, um, their I guess their genitals are so variable, so variable. Some of them are more penis-like, and some of them are more vulva-like. So I think it just depends on which version you have of intersex, and of course you build things from there. But obviously the basic structures are still there, right? Everyone has a urethra because you can't live without it. Uh,
Mhm.
and then the rest of it, it just again depends on like which way it was leaning towards, regardless of like what's inside, right? In
Mhm.
terms of like, oh, they have a really small uterus, or they have ovaries inside, but then testicles on the outside, that kind of thing. But it is pretty rare to see, you know, um, well, I guess I shouldn't say true intersex, but like fully, like presenting cases of intersex, where it's pretty obvious.
Sure. And for the folks who are asking questions right now, I'm kind of just going from the previous most ones going up into the most recent. So if your question hasn't been answered yet, it's because I'm working from the past into the present. For phalloplasty that preserves your other anatomy, is it still possible to have an erectile device? If so, what types?
Yes. So, yeah, so if you just have a phalloplasty, you don't do anything underneath, you can have a erectile device, and it just depends on the surgeon. You can have any kind of device there. And it's a matter of picking the right one so that if it has like a balloon to activate, you can put it sort of on top of just above the pubic bone. And there's others like malleables, and you can see that on that one that I showed that was infected. That's a form of malleable, but that's just a silicone rod. So you'd have to talk to your surgeon about which type would fit the best for your needs. But yeah, you can put any erectile type device in a phallus only person.
Cool. For scrotoplasty with testicular implants, are expanders required, or does it vary based on the patient?
It varies based on the patient, how much scrotum there is after the scrotoplasty, um, but also what size testicles the patients are looking for.
Cool. Is a hysto and a vaginectomy required for a groin flap phalloplasty?
Not for a groin flap phalloplasty, um, unless you're planning on eventually going from groin flap to urethra and then urethral lengthening. And it's at the urethral lengthening step that I would require a vaginectomy. So again, it just depends on which path you're trying to go. But urethral lengthening, primary urethral lengthening, vaginectomy.
Got it.
Absolute for me.
Sweet. This person says, for metoidoplasty, they know that the size is highly dependent on bottom growth, but are there certain surgical techniques that can make the phallus bigger in length and or girth? And is it still recommended to have testosterone gel applied directly to the clit for a while to enhance the growth beforehand?
Um, yeah, you can certainly do that. Interesting that I read an article, it's been a while. I read an article where cis women are using testosterone cream on their clitoris because they want it bigger. And so yeah, you can certainly do that.
For sure. Um, let's see. Will everything be the same color, or will it always be different and obvious that you had the surgery?
As in phalloplasty?
Yes.
Um, uh, no, everything's the same color because it comes from the same flap. And so one of the options is tattooing. And I've seen this on the internet, but you can basically tattoo the tip so that it's a darker, like sort of pinkish color. And I've also seen examples of tattooing veins onto the shaft.
Wow. That's amazing.
But I mean, it looks very natural. But you have to want to pursue that, obviously.
For sure. If you have a tendency to scar and get scar tissue, what would be the best option?
I get that question frequently. And it really just depends on the person because sometimes they say, oh, I keloid, and they show me a scar and it happens to be like right over their knee. Well, the knee is just a bad part, like a bad place for any kind of scar because obviously you're bending it all the time and it really affects the healing. Um, and so it doesn't necessarily mean that when you have bottom surgery that you're going to end up with keloids or thick hypertrophic scars. It actually doesn't usually happen, at least in the genital area. I've seen it, but it's probably like very few people where they have truly bad hypertrophic scarring. Not keloids. I've never seen true keloid scarring, but certainly bad hypertrophic scarring I've seen, but very, very rare. But it depends on patients' skin types and everything. But for some reason, the groin area is somewhat kind of immune to it, I feel like. Otherwise, I'd be seeing it all the time, right? I do so much bottom surgery that I'd be seeing all these patients with like really thick, ugly scars, and I just don't see it.
That's great. Do you have a BMI limit for these procedures?
I do, and it really depends on what procedure it is, but my office can tell you what they are. They're stricter for certain things, like I said, like the ALT flap, um, and some of the microsurgical flaps. There is a limit, and there's a reason if you care to hear it. Is that if you have a higher BMI, you have more subcutaneous tissue. And let's say that person wants a phalloplasty and they're on the heavier side, I have to attach the penis to like the pubic region, right? And so I don't attach it, and I try to attach it as close to the bone as possible, but I can't. I have to attach it to the skin, which is not a problem. But then guess what? The blood supply, that leash, is only so much length that I can take. And
Mhm.
so if it can't reach, if the nerve can't reach the clitoral nerve, then I can't do it. If the urethra portion doesn't reach the extended urethra portion, that's a problem because you're having to traverse through this much tissue instead of this much tissue. Okay. So that's kind of the reason why there is a limit to some of these flaps.
For sure. That's really helpful to know. And I just posted the gender confirmation website. Rosie just sent in the BMI requirements as well.
Oh, okay. Thank you, Rosie.
So, yeah. Is there more sensation in one surgery than over another?
Yes. I think out of all the flaps, the radioform um, probably has the best chance of having good erogenous sensation, whether that's in the form of a urethroplasty from someone who has a phallus already but doesn't have a urethra. If you put a radioform urethra only, um, the nerve will grow through it, and they'll get erogenous sensation through the inside of the phallus, and of course the tip is it's externalized, right, where you pee from. And I've had patients that have had this; they have had full sensation, and if you tap the hole of the meatus, they jump because
Wow.
it's like I just flick their clitoris kind of thing. So it's amazing to see that.
Wow. That's amazing. Cool. Do you use buccal tissue to create or enhance the urethral accretion in the urethral lengthening surgery?
What do I use? What tissue?
Do you use buccal tissue?
No, I don't. I reserve buccal mucosa to fix either fistulas or strictures.
Okay.
Yeah,
Let's see. You mentioned using only one of the cylinders in the pump ED to prevent pressure necrosis. Does that still provide full erection?
it does to the point where it's functional.
Sweet. What impact does being diabetic have on bottom surgery choices?
It doesn't as long as you have good control of the diabetes.
Mhm. Do you have any recommendations on reputable gender surgery centers in Texas?
Crane Center does a lot of phalloplasties. They probably do the most in the country. I saw them present at WPATH in Portugal. Um, and they do a lot of research and stuff like that. They still get complications, but they just do a lot of volume because they have an army of like bottoms, like phalloplasty surgeons there. So that's the only place I can think of in Texas. Plus, it's pretty well known nationally and internationally. So, but we all, but they also present their complications and anybody who does phalloplasties, we sort of share the same pain of the challenges of getting complications like fistulas and things like that. So I was saying to a patient just today about the metoidoplasty and complications that sort of hearing some of these major centers in Europe and like the Crane Center talk about things is like, oh, thank goodness I'm not the only one that's seeing complications in these complex surgeries. So yeah, they're very challenging cases. But of course, it is successful. It can be successful. It might take a little bit longer. Otherwise, no one would be doing this, right? If it was like failure after failure after failure, it doesn't go that way. It does work. It's just a matter of how long it'll take to get there.
We only have a few left. Are there specific insurance companies that are easier to work with for getting surgery procedures done with you at the Gender Confirmation Center?
That I don't know. Maybe Rosie has an idea.
The only one that I can think of that's generally easier to go through is Aetna because they're actually following the WPATH SOC 8 like latest requirements, so you only need to get one letter. But other than that, all insurances are kind of the same in terms of them if you're going through a commercial plan. We just always recommend a PPO if possible.
Got it. Thank you. Um, uh, what it would be the likelihood of being able to stand to pee with metoidoplasty and urethral lengthening?
Um, that depends on how much growth someone has had. Um, and it also has to do with weight, right? So if someone's heavy, there's just so much surrounding tissue that even though they've had really good growth, it can't be pulled out far enough to kind of clear tissue. Um, or someone that has not had very good length and growth, even if they're not heavy, it's hard to sort of clear the zipper or the pants in doing that. So it's just variable. It depends on how well it pulls out, how well it releases, what surrounding tissue there is. But sometimes that can be helped by, again, cutting the tissue from the upper, like scrotal region, and then doing a monsplasty to pull the penis more forward. Things like that. So, but I'm pretty forward with patients to tell them that, yes, you're definitely in the category of being successful doing it. To others where, they've literally had no growth even on testosterone, and I tell them, I can still do it so that you have the right anatomy, but you more than likely won't be able to stand to pee.
For sure. Does age impede healing for any of these surgeries? This person says they're 40 and trying to pursue fallow.
No, it has to do with physiological sort of age. And so I've done phalloplasty with urethra and everything on, I'm trying to think how old this patient was, 60 maybe.
Amazing.
Yeah, and they did fine. The only thing is that their arm didn't heal too well. And they didn't really follow like the therapy sort of sequence. And because they were 60, they got pretty stiff, and we needed to do scar releases to help the motion of the wrist and the hand.
For sure. Have you needed to do a Mons reduction for phalloplasty before? Is that necessary?
Yes, again, it just depends on the person. Sometimes I do it before I do any other surgery. Because of weight issues, I don't quite qualify for phalloplasty, but it's just one step forward. One step closer, rather than tell someone, oh, you're just too big, you can't do any of this. I can at least offer that as a preparation to thin that segment while they're, working on losing weight and things like that. So yeah, that's a recommendation for those who need it or can use it again as at least one step forward, so they're not feeling like they can't move forward because of their weight kind of situation.
And then one of the last ones, what is the percentage of getting an erection and being able to have sensation?
Well, if you have an erectile device, obviously you can get erect whenever you want to and for as long as you want to. But for like say metoidioplasty or something like that, I actually don't know.
Mhm.
But maybe someone in our audience can tell us about that if they're willing to share. I don't know that answer actually. I've
For sure.
never asked, I guess, but
Cool. Thank you. I think that is the last question. Thank you so much for being down to stay for a little bit longer. We answered like 30 something questions thanks to you and also Rosie as well.